Okay.
Let's get started. Good morning, everyone. Today we'll have lectures about medication safety. As you know, it's a very important topic for us as pharmacists. We need to avoid any medication errors. That's why we need to focus on the medication safety. For this lecture, we have the following objectives. We need to define the term adverse drug events, and we need to know what the difference between medication errors and adverse drug reactions, and the relationship between them and adverse drug events as well. We need to know the type of medication errors, the origin of medication errors, and we'll give you example from the United States, how the system there, how can we avoid medication errors, whether it's prescribing error, dispensing error, administration error. So everything today about adverse drug events and medication error. Medication safety. Why we care about medication safety? We need numbers. In terms of numbers, we have 1.5 million people in the United States die annually due to medication-induced harm, due to inappropriate medication use. So that's why it's important. We need to save so many lives here. As you know, in the United States, they have a reporting system. They report the adverse drug events. And for the medical enrollees, with those elderly people above 65 years old, yearly they have 530,000 preventable adverse drug events. When I say preventable, so those are medication errors, so we can prevent them. Annually, we have like 500,000 adverse drug events in the United States. Also, we have 200,000 deaths annually in the United States due to medication-induced harm. So as pharmacists, we can do something. We need to prevent those medication errors. We need to save lives, improve quality of life by preventing adverse drug events and medication errors. Let's define adverse drug events. Adverse drug events, unintended medication-induced injury or harm. So it's unintended, it's unintentional, but it happens. So something bad happened, there's injury, there's harm, okay? That's why we call it adverse drug events. So how can we identify adverse drug events? We can identify drug events either by vital signs, or by blood pressure, or by sign of symptoms, such as warfarin-induced bleeding, okay? This is one of the sign symptoms. While vital signs, other ones, we can identify blood pressure, okay? Or we can identify by using antidote, like if we saw naloxone prescribed, there's something wrong, there is overdose in opioid. So we can know if there was adverse drug events already happened or not. So we have sign symptom, we can use vital signs, we can use antidotes to know if there was an adverse drug events or not. And then I'm talking about the patient charts. Patient medical record, or call it charts, record, they are synonym. So we need to understand what are the differences between adverse drug events, adverse drug reactions, and the medication errors. Those three terms, they may use them interchangeably, but they are not exactly the same. We need to know what are the differences. This is my literature review I published in JAMA, the Journal of American Medical Director, in 2017. This tries to simplify those terms. As you know, we have the physician, and the job of the physician or the role of the physician is prescribing. So in prescribing role, we may have error. So we call it prescribing error. Can we prevent this prescribing error or not as pharmacists?
Yes.
Yes, we can do. Dispensing errors, who usually, as a pharmacist, we do the dispensing. So we are the first one responsible about any dispensing error. The third type of errors could be administration errors.
Yes.
It could be nurse, could be patient themselves. Why? Because at home, patient take the medication by themselves. Because at home we don't have nurse to give medications. So in the hospitals, we have the nursing staff, but in the home, we have the patient themselves. So patient can take the extra dose of insulin and will end up with hypoglycemia, which is one of the severe or serious adverse drug events due to insulin-induced. Finally, monitoring errors. Monitoring errors is the duty of every healthcare provider. As pharmacists, we need to do monitoring. Nurses need to do monitoring, and patient themselves. Because in the hospital, we need to review patient lab data. We need to review their vital signs. Because why we need vital signs every day? Why we need lab data every week? We need to monitor.
Efficacy and safety.
Safety, because our issue here is safety. We don't need to keep giving warfarin when patients have very high INR, above 4.5. So this patient will have, next week, if we don't stop or hold the warfarin today, next week this patient will suffer from bleeding. So we need to monitor INR, so prevent warfarin-induced bleeding next week. That's why we need to monitor. So it's the responsibility of every healthcare providers. At home, we need to educate patients. How can they monitor their blood glucose? You teach them how can they use blood glucose meter so we can keep them safe. We need to protect them from which adverse drug events? From hypoglycemia. Okay? So monitoring, it's really broad term. Everyone is responsible here, even the physician. When the physician asks the patients, you need to come next month. So in the next visit, we need to check their vital signs, we need to check their lab data so we can prevent any adverse drug events in the future. So if there is something bad happening here due to any of those errors, like prescribing error, dispensing error, preparation or administration error, or monitoring error, those called medication errors, okay? Medication errors could be harmful, could be non-harmful. Harmful, as I say, we gave the high dose of insulin, we end up with hypoglycemia. This is medication error. Some medication errors are non-harmful, such as if I give the amoxicillin maybe before meal or after meal, it could be a small error, but maybe it doesn't harm. Okay? If I give it not every 8 hours, I will give it, 5 hours, then 8 hours. This is error, but it's still not serious error. So not all medication errors are harmful. Keep in mind, we have some errors that are not harmful, but we have others that are harmful. We have those medication errors, we call them preventable adverse drug events. So adverse drug events, they are either adverse drug reactions or medication errors. For the medication errors, they are always preventable. When I say preventable, we can prevent it as a healthcare provider team, not just pharmacists. But when I say preventable, so any medication error should be preventable. But we have another cause for adverse drug events, which is adverse drug reaction. We call it sometimes side effect. Those are usually, not always, non-preventable, such as dry mouth due to anticholinergic, first dose hypotension due to captopril,
anaphylactic reaction.
Anaphylactic reaction. If we know the patient history, this could be medication error. But if we don't know, this is the first time, so we'll end up, because it's a gray area. I can see your point, but we need to make sure, because every medication, this patient, when I visit the nursing home in the state of Iowa, each patient has a list of all the medication allergy. They put it in their charts. This patient allergic from 12 medication. So the next time, the prescriber will not prescribe any of those. If they prescribe any of those again, and they will have an anaphylactic reaction, we'll end up with medication error. But if this is the first time, we don't know. Okay, like for example, if we give Keflex or Civalexin and cause diarrhea, it's kind of non-preventable, because maybe if this is the first time, because we don't know if this patient is sensitive to this dose of Keflex. So if it's normal dose error, we usually call it non-preventable adverse reactions. If it's preventable, so it's a medication error, okay? We have two types of medication errors. We have harmful and non-harmful. There is another type of adverse drug reactions, which is the preventable one. Like some subtypes of systemic lupus erythematosus induced by medications. Those are dose dependent, some of them. So with high dose, we cause them. With low dose, maybe there is no adverse drug reaction. So keep in mind, even adverse drug events, which is side effects, could be preventable. Mostly they are non-preventable, but some of them could be preventable. Okay? So keep in mind, adverse drug events is a broad term, which is caused by either medication errors, which is usually preventable, or non-preventable due to adverse drug reaction.
No side effect.
Side effect or adverse drug reaction. Those terms usually the side effect refers to minor adverse drug reactions. When we say side effects, usually tolerable, but some adverse drug reactions could be intolerable. So keep in mind, side effect, they don't use it so much in the research, they use adverse drug reactions. That's why I'm focusing on those terms, because if you go to the research, it's not commonly used side effect. It's only used for the guideline could be, but for the research, they usually use adverse drug reactions, adverse drug events, and medication errors. Okay? You have questions so far about those terms? The next step here, medication errors. What's the difference between medication error and adverse drug reactions? Could someone tell me what the difference between those two? Yes, go ahead.
Medication error, for example, the dose is incorrect. Adverse drug reaction, unexpected. For example, disopyramide can cause most cases systemic lupus erythematosus, as you said. Disopyramide hydralazine, aplastic anemia by chloramphenicol.
Preventable or non-preventable?
Exactly. So,
Unexpected.
in general, we can say medication errors are preventable. Adverse drug reaction usually non-preventable.
We can say that medication error is caused by a person who is in charge. For
Yep,
example,
usually provider.
nurse or a physician.
But medication errors could be done by the patient themselves. If I take the extra dose of insulin,
Exactly.
there is medication error,
But the adverse
which is
reaction-
administration error
But that adverse drug reaction is caused by the drug itself.
by medication. Both of them caused by medications, because both of them they cause harm. But this one, I like your idea. There is a person in between who caused the error, which is, I think it's nice to say that. But adverse reactions, it's not a person fault. Here, there's a person fault usually, either patients or healthcare providers. So keep in mind, medication error is usually preventable. So all the idea here, we try to avoid medication errors. We teach you guys here, so you go and prevent medication errors, because it's hard to prevent non-preventable adverse drug reaction. So we will focus on medication errors because we can prevent them. Okay, this is what we can do here. This is the example, as Mohammed said here, hydralazine-induced systemic lupus erythematosus. If it's dose related, it could be preventable. So it could be from medication error. Okay. Here the percentage of adverse drug events in the United States, almost like 20%. And usually they record the adverse drug events, they record it where? They record it in the hospitals and long-term facilities. In the United States, they have long-term facilities, which is facilities, they have, some of them, they call them nursing homes. They have staff for 24/7, nursing staff. They usually take the patients from the hospital. Like for example, if patients experience CVA, and this patient have paralysis, they usually don't charge them to the home directly. They hospitalize for 10 days in the hospital, and they will discharge them to nursing homes. Nursing homes, they do the rehabilitation for them, physical therapy for 1-2 months, like a couple months, then they discharge them to home. So it's intermediate healthcare facilities with 24/7 nursing staff. So when I say it's easy to follow any medication errors in hospital or in those long-term facilities, but it's harder in home. It's harder in the community because if we need to record it, we need the collaboration of the patients with us. We need to set the patients either tablet to record or phone to record their adverse drug events. That's why it's easier in the hospital because we can monitor them 24/7. When I say 24 hours over 7 days, that's why I say 24/7. Adverse drug events are caused either by error of commission or error of omission. What is the difference between those two terms? Error of commissions, there is something happen. There is action happen already. Like for example, I gave the wrong dose. I gave the dose of insulin, which is the high dose. I caused the hypoglycemia. But omission, I missed the dose. I missed the dose. I didn't give the insulin. I ended up with hyperglycemia. Can you see this? So in commission, you did something as healthcare providers. We did something. We took the wrong dose. We took the wrong medications. We took the wrong regimen. But in the omission, we didn't do anything. We missed the dose. We missed the dose. We missed the antihypertensive medications. We end up with high blood pressure with CVA. Can you see this? This is omission or commission. Adverse drug events could be physical, bleeding, could be mental, could be like, for example, because dizziness. You are a driver and you took diphenhydramine. We end up with what? With dizziness. Dizziness could cause you harm. So it could be physical, could be mental, could be cause confusion and hallucination. I gave this topic about psychotropic medications. They have adverse drug events of hallucinations. So adverse drug events could be mentally, could be physically. And it's harder to monitor or to record the mental because we don't have vital signs or lab data, but easier to monitor the physical one. So keep in mind adverse drug events either or loss of functions. I say if you are a driver, you cannot drive because the diphenhydramine. Keep in mind if there is harm to the patients, who caused the harm? Usually the series of medication errors. Because when I say series, I meant prescribing, because physician usually prescribes medications. Pharmacists dispense the medications, nurse administer medications, and all of us collaborate to monitor. So if I didn't identify any prescribing error, and I'm supposed to be pharmacist, I'm supposed to be the second line defense of the physician. Physician had inappropriate prescribing, I didn't catch it. So and the nurse didn't catch it. So we'll end up to the patients, and patient will end up with a harm. So it's usually a series of errors because we need to. That's why it's multiple. But every one of us as healthcare providers, we need to prevent, or we are gatekeeper. We try to prevent any adverse drug events because our duty as a pharmacist. So whether it's community pharmacy or in the hospital, our duty. Number one duty to keep the patient safe. How can we keep the patient safe? We need to review the medications, the prescribed medications. If we don't catch any inappropriate prescribed medication, this inappropriate prescribed medication will cause harm to the patient. So that's why when I series, it's not the fault of single. It's not the fault of physician themselves only, because we supposed to identify any medication errors. Why we didn't do that? So it's series. The nurse after us should also try to review. So it's series of failure when I say adverse drug events. There is a tool which is adverse drug events trigger tool. It's developed by the CMS in the United States. Simply, we have 17 medications. Those most commonly cause adverse drug events, such as opioid, antihyperglycemic, psychotropic medications, antihypertensive, anticoagulants, they have list of ADE trigger tools. They have list of lab data, list of vital signs, lab of sign of symptoms. They help us as pharmacists to identify any adverse drug events in patient records. So as pharmacists, you need to review the medical records, okay? If you find in the medical records, this patient had phytomenadione, which is vitamin K, this is indication of what? Indication of warfarin-induced bleeding. This patient experienced bleeding due to warfarin. That's why he took the vitamin K. When you find something like extra 50% or glucagon or both, you say this patient experienced hypoglycemia. So this is the indication this patient experienced adverse drug events, and you can record it. Naloxone, a patient had experience with overdose of opioid. Digoxin immune fab, if digoxin toxicity, which is rare here, because I don't think it's commonly used now. Protamine sulfate, if it's heparin-induced bleeding. And sodium polystearate for any AC inhibitor or direct-induced hyperkalemia. So keep in mind, when you are looking at the charts and you find one of those antidotes, this is the sign this patient experienced one of those adverse drug events. So this list will help you to record any adverse drug events. And if they have any adverse drug events, so you can collaborate with the prescriber to prevent recurrence of those adverse drug events. This is the scheme, I think it's in the, this is in the hospital. As you know, in the hospital we have series of orders. We have prescribing by physician, we have dispensing by pharmacist, we have administration by nurse, we have the monitoring by all healthcare providers. So if I ask you, who is responsible for medication monitoring error here? Who is responsible for the medication errors?
All of us.
All of us as healthcare providers, because it's an institutional setting, which is hospital, okay? But if I say in the at home, who is responsible for any medication error?
Patient himself.
Mainly patient themselves.
Relatives of the patient.
Or the relatives, because we don't have healthcare providers 24/7 at home. If it's long-term facility, where I conducted my research, responsibility of the nurse. So keep in mind, at home, the monitoring errors, mainly it's the responsibility of the patient themselves. I think our duty, it's kind of, it's not simple, but we need to know our duty as a pharmacist. The first, we need to make sure this medication is safe, okay? So we need to make sure of five rights. The right medications in the prescription, the right route, the right time and frequency, and the right patients. Don't give this patient another dose, another prescription for another patient. Right dose. So we need to make sure those five rights before we dispense any medications, okay? Prescribing error, as I mentioned, is responsibility of who? Physician. But do you think, do we have any role to prevent those?
As a consultant pharmacist.
As a consultant, we usually at hospital, even at community pharmacy, we need to review any prescribing medications. We need to prevent those adverse drug events and medication errors. Administration error, as you can see, either wrong time, improper dose error, if we give the higher dose, low dose, wrong route or technique. Wrong route, like if it's IV, we give it IM, it's not so much harmful, but if it's IM, we give it IV. It could be fatal. As the benzethine, there is a case of newborn baby. They gave him benzethine IV, and he eventually died because this high dose in the United States. So route is really could be fatal, the wrong route. So keep in mind the route is very important here. Dispensing errors, it's our duty. We need to make sure we avoid all the incorrect dose, incorrect dosage form, incorrect frequency, incorrect route. As a pharmacist, we need to make sure all those. Deterioration, drug errors, we need to make sure it's not expired, the medications. Minimizing dispensing error by pharmacists. What should we do to prevent those? We need to make sure the name, age, birth date, allergies, and diagnosis. As Dr. Bala said here, allergies, we need to review any previous allergies. They should be reported. We need to review them. If this patient experienced previous penicillin allergy, we need to avoid any future penicillin derivative. As Selfa as well. Review drug information, as I said before, communicate with the prescriber. I think in Iraq, we may have weakness in this area, communications with the prescriber. Who are our prescribers? Usually physician in Iraq. We need to, in the hospital, as a clinical pharmacist, we need to communicate with them because they are the prescriber. We don't have the authority to change the medications. But we have the right to recommend something or to advise the physician. So our duty here, our role is to communicate with the, if there's something wrong or inappropriate prescribing, we need to tell the patient, the physician. We don't, as Dr. Leah said early today morning, we don't have to attack the physician. We just try to communicate with them in a friendly way. So, Doctor, what do you say? I think this medication, maybe we prescribe a higher dose than recommended, or this could be causing harm. Why? He will ask you why you have the reference. So you will say, this may have allergic reaction in this patient, or this dose, it's higher than the recommended, or it's a prophylaxine, doesn't prescribe for less than 16 years old, or whatever the cause. You should have the legitimate justifications. You should have the reference before you talk. So try to communicate with them friendly. We try to, because the friendly relationship, the trusted relationship, which is built in our knowledge, in our trust, in a friendly way, they may change their prescribing. We need to keep in mind anything, we cannot change the medication regimen by ourselves. We don't have this authority. But we need to communicate with the physician. If there is inappropriate prescribed medications, we need to tell them about it. And our duties usually verify expiration date, counting, measuring appropriate amount, and putting or affixing appropriate label or auxiliary label. Auxiliary label, in the United States, they have electronic system, and electronic system, the good things here, they have computer. And in the computer, each patient, we have all the information about the patient allergy, date of birth, and the past medication history. And the computer could help us if there is drug interactions.
And hepatic function.
Anything about this. So we will receive computer alert, which is good in electronic health care system. That's why we may need the electronic health record here. They will help us to identify any of those drug interactions. I think some of you may saw this before. Have you seen this before? Maybe Dr. nodding in his eye. Here?
سويناها للطلاب بالعربي ويزلونها بال.
Which is, I think, yeah, it's the same idea. We have auxiliary labels. We need to put this label on the vial, because usually in the United States they have the medication on the label, on the vial, not as a sheet or blister. And we can fix one of those on the label. If it's after food, like non-steroidal, or it needs extra cup of water, or it's rectally used, or cause drowsiness, diphenhydramine. Why do you think we need those auxiliary labels? We need to keep patients aware about any side effects, and also about appropriate use, because this sticker will stick on the vial, medication vial, and always when they take a look at the medication, they can see those labels and remember how can they take these medications. And I think if we have this label, Dr. They already did this in Arabic, if we can do this in a systematic way in our pharmacies, in our community pharmacy, I think we can print those stickers in Arabic and we can use them on the plasters. I think they are very helpful. and they will prevent many side effects or adverse drug events, and even educate patients. In the planning, we didn't prepare well. We didn't know beforehand. It's something in the planning, something in the rule, something in the knowledge. But if it is skill-based mean it's due to unintentional. You know the rule, you know the skills, you know the knowledge, but it's called by unintentional. I will give you an example here. Skill-based, we call it unintentional blindness. Like you need to dispense Endiral 10 milligrams, and unintentionally you just grabbed the wrong one. You grabbed the Endiral 40 milligram. So this is unintentional blindness. In your mind, you know the rule, you know everything, but it's by lapse. We call it by lapse. You took the wrong sheet and give it to the patient. This is skill-based. What are the causes of those? In the United States, they usually have very busy pharmacies. And like per day, they have 300 prescriptions. And they have only like 30 minutes maybe for lunch break. And they are very busy. So they don't have enough time to, they have distractions, they have phone calls. So we need to reduce the interruptions when, like, I advise you as Iraqi pharmacist, when you dispense a prescription for one patient, don't talk with the others. Just focus on one patient at a time. You need to finish with this patient before you talk with the others. In Iraq, we have like 4 patients usually talk at the same time, which is our culture. But we need to focus on one because we'll make mistake if we don't focus on one. We need to finish this patient first because we will have maybe unintentional blindness. We will grab the wrong sheet. So try to reduce the distractions, interruptions, and in this way we can prevent the skill-based error. For the knowledge-based error, like for example, if we don't know something about this topic, we should not advise the patients. Like if a pregnant woman came to you and she asks you, I need a safe anti-emetic medications for me. If you don't have this knowledge to choose the right, appropriate anti-emetic medications for morning sickness for her, don't do that if you don't know that. So make sure you have the knowledge before you act. It's okay to say, sorry, I don't know, or ask the next pharmacy, or come to me later so I can make sure which one is safe for you. It's okay. It's better than you dispense the medication you are not sure if it's safe or not. So it could harm the patients, could harm the baby. Make sure you act within your knowledge.
Lack of updating knowledge about the drug.
Exactly. If you don't know how many times we need to measure the NR per week or per month, and the physician asks you, it's better to say I will check for you later and let you know. It's better than saying the wrong one or you are not sure about it, because if it's wrong one, they may not trust you again. So make sure, update your knowledge. That's why you need to, as pharmacists, you need to keep update with all the information after graduation. Rule-based. Rule-based, we know the rules. We should know the guideline. The guideline treatment for this antihypertensive, number 1, number 2, number 3. If we don't know the rule, or we know the wrong rule, or we only know for example, the adult's dose. If we don't know those appropriate rules, we may apply the wrong dose or wrong. So rule-based, we need to make sure we know the rules. In the United States, they usually have guidelines. I think in Iraqi hospital, we also need this. We need guidelines, and most of physicians, they know the guidelines, but we usually need systematic guidelines. Like each hospital or the physician should follow one guideline. But in Iraq, we may have variation. Depends on the physician themselves, their skills, their years of experience. We may have variation in the guideline, but in the United States, each hospital has its own guidelines. Like They should follow like American Association of Diabetes. They usually they follow the guidelines for the diabetes patient according to American Diabetes Association.
Mayo Clinic.
Mayo Clinic. They usually have those guidelines. So if you make mistake, they will look to the guideline. If you follow the guideline, you are safe. But if you didn't follow the guideline and you made mistake, you may be responsible. So keep in mind, you need to follow those guidelines. How can we prevent the rule-based errors? You need to learn the wrong rule, and how can we avoid the wrong rule? We need to learn the right rule. Like for example, the dose for patients. We need to know the right dose. Either also due to apply the wrong rule, and their system in the United States, they call it computerized prescribing order entry. The physician, they have system in their computer. This system helps them to choose their appropriate medications. They will click on which medication they need to choose and what's the strength of these medications, and this system will help them to choose the appropriate one. So everything is computerized. They have an electronic system, this one called computerized prescribing order entry. This is for physicians. For also, they use this system to send the prescription to the pharmacy, electronic prescriptions. And the pharmacy, when the pharmacists usually receive those electronic prescription on their computer, they have computer in their pharmacies, they open the system, they found a prescription for these patients. They should have all the information about the patients so they can review the information before they dispense, which is usually helpful. This electronic prescribing systems or electronic health records really helpful, and it's really because we have all the information about the patients. And in Iraq, usually we have the handwritten prescription, the paper one. I don't have any information about these patients because I only have this prescription, which could contain the name, age, gender only. We don't have any history about the medication history. We don't have allergic history. So this is the importance of electronic system. We have all the information there. We can check. So this is other advantage of electronic prescribing system. Electronic drug utilization reviews. As I mentioned, this system, this is the pharmacy system. We call it electronic drug utilization review. It's required by law in the United States. You must do this for new prescriptions. You must check drug-disease interactions, drug-drug interactions, any allergy, any inappropriate dosage, any inappropriate drug duration, or any abuse, even the abuse. Those patients on opioid, we call them abused. So you have the system, you have date of birth, you have the Lasix seer tablet, you have even the shape of the tablet. You make sure, is this the right tablet or not? So you can check the tablet here. So this system helps us to identify any potential and appropriate prescribed medications. They have automated machines, they have electronic systems. One of them based on barcode scanning. Barcode scanning is really cheap, affordable system. We need a barcode scanner which is connected to the computer. And this one connected to the computer. When we scan the medications, we make sure that we need to scan the medication, we need to scan the prescription. This is the bottle prescription. Help us to make sure this is the right medications for the right patients. So it's not expensive, but we need to make sure this is the right medications, the right patients. And I think we can do this in our pharmacy because now in supermarkets, in good supermarkets, they have this barcode scanners. And it's not expensive system. So we can use it in our pharmacy, especially in the hospital pharmacies. We need this.
Wristband.
Yeah, wristband. Wristband, even in the United States. For inpatients, you usually have wristband. It's a good point, Dr. Leah. the patient usually have wristband. Even as outpatient, when I go to the hospital in the United States, when I went there, they usually put the wristband and they scan me because this wristband has my informations, date of birth, my name, my conditions. And when they scan there, they need to match the medications with my name, with my information. So it's matching. It's a second step to make sure this is the right patients. We have barcode technologies. How can we make the barcode? We can put the bulk of the medications, the bottles of the medications. They usually use the bottles like 300, 400 tablets on it. Then they put those bottles inside these machines, and this machine can put the barcode for them. So it's barcoding system here. This system helps us to barcoding the medications. We have another systems. I think this counter, this is the tablet or capsule counter, which is, I think it's not expensive. Instead of we count by ourselves with all the contamination, we just put the capsule here, and they will count for us 95 capsule, and we put it in the vial here. We have another system here, which is dispensing technology systems. Like imagine we have we have it in the emergency room. We call it دولاب الأطباء. دولاب الأطباء. We can put the medication for them here, and they can scan the patients, or they can enter the information here, and they can get the medication they need. The appropriate one, the correct dose. So we have those also automated dispensing cabinet. Those dispensing cabinet, everything is here. You only enter the amount you need, the item you need in this system, and you will get it directly.
Robust.
So this is another one. It's not just, So it's all those systems help us to avoid any medication errors, dispensing errors. Okay, this is dispensing cabinet. So we have automated dispensing cabinet here. Will help us to count the medications, and especially in the United States, they try to buy those in the big hospitals to avoid any medications error, especially dispensing error. So those machines will help us to prevent dispensing error. Safety culture. We usually have two culture. When I say culture, it's not like our community culture. It's the hospital culture. It's the healthcare setting culture. We have two kind of cultures. Unfortunately, we have blame culture. Even in the United States, they still have blame culture. When I say blame culture, if there is something happen, if there is medication error, we need to blame someone. Punishment. We need to find who is responsible for this error. Is it the nurse? Is it the physician? Is it the pharmacist? We need to blame someone. This system usually focuses on punishment, but we need system to focus on preventing the error, not just punishment. We may send reminder, but because, can you tell me the disadvantage of this system? If we focus on the blaming. So, do you imagine what will happen here?
Underestimation, sir.
Underreporting. Underreporting means if there is an error happen, the nurse will not report it. The pharmacist will not report it. We gave the wrong dose, nobody knows, just skip it. Just don't ask, nobody asks you, don't tell. So we hide it. This error may repeat again and again. So keep in mind, this is not corrective system. Everyone tries to hide, even in the United States. So we need to avoid this. Like if it's minor, no harm, nobody knows. I just gave it 4 tablets instead of 3, nobody knows, no harm, just don't tell. Okay. So if there is a harm, you cannot hide it. If this patient experiences bleeding, you cannot hide it. So we need someone to blame. Find someone to blame. And that's it. We just punish the nurse without any correction. But the idea, we need just culture. Just culture is the opposite. We need our healthcare setting culture. Just culture means we need to find what the reason behind the error. Is it the distraction? Is it the system? Is it the double checking? So we need to find what's the reason behind the error so we can prevent it. We may need to follow the guideline. We may need to reduce the distraction. We may need to send our staff to training workshop to improve their skills about warfarin INR monitoring, because they don't know about warfarin INR monitoring. We need to send them for workshop to be trained for those INR monitoring. So we need to know where's the problem. Our staff, they don't know how they monitor the warfarin. And in our ward or in our hospital, we usually use the warfarin. Everyone here should know about warfarin. If you don't know, we need to send you to the workshop or to the conference or meeting or continuing educations to make sure you know about the warfarin. So just culture usually doesn't focus on the punishment, focus on the corrective actions, whether it's minor or major. We need to find what's the reason behind it. We need to prevent it, okay?
In a blame-free environment.
We try it's blame-free, but even in the nursing homes, I visited in the United States, they usually have annual surveyors mean inspectors. And inspectors, they come to the nursing homes every year, once a year, and try to find the errors for them. And if they find an error, they will punish them by citation, by penalty. They will charge them money for this, and they will reduce their rank. They have 5 stars ranking, and they may give them not like 3 stars or whatever, or even 1 star if you have so many adverse events or problems. So they try to hide it because you are looking for the errors. So I will hide it, because if I hide more error, I will be 5 star. So it's a blame culture. Finally, I will just give you example about the real case happened in 90s in the United States about medication errors. A patient prescribed one of the diuretics, which is the thiazide diuretic metolazone. The brand name is similar to the brand name of another medication. Here is zaroloxolin. It's similar to Zaya. They are like Z, start with Z. As you can see, the pharmacist had a dispensing error. Instead of dispensing metolazone, they dispensed this brand name, which is similar to this one, but this medication contains hydrochlorothiazide, which is also thiazide diuretic, but plus beta blocker, bisoprolol. So this patient took this combination in a state of metolazone. After a while, this patient experienced weight gain. So he was hospitalized, and nobody knew about what happened. What is the problem? Then the physician discharged it from the hospital to home. Say, just increase your dose, because the physician was thinking he was taking metolazone. So say, increase the metolazone, so your edema will be fine. But this patient was all the time was taking this combinations, and nobody catch this error. What happened next when this medication finished? The patients took the prescription and took the vial, the empty vial, to the same pharmacy. Say, I need to refill because it's done. At that time, that same pharmacist checked the vial, checked the prescription, say, oh, okay, they are not the same. I made mistake. He found the mistake. So far, and at this point, now we have 2 routes. Either we can contact the physician and fix everything, or hide it, and we'll see what will happen next. The pharmacist took the wrong action. What the pharmacist told the patient stop the medication immediately and take the right one. This medication contain beta blockers. As you know, beta blockers, if you stop the beta blockers immediately, you will have reflex tachycardia. Because you know, all those times you have those saturated
Rebound hypertension.
hypertension and rebound palpitation. They stop it immediately without tapering, without telling the physicians, and patient experience myocardial infarction and eventually death. So when the family found out this, they sued the pharmacy and the pharmacist, and the court charged them 1.2 million to pay to the patient family. So this is example of what? Of dispensing error. So the take-home message from this case is we need to communicate with the prescriber. Just use the phone call or visit them. Don't act without collaborate with healthcare providers, with the prescriber. We need to call them. We need to communicate with them. If this pharmacist called the physician, they may did the tapering. We may save the patient life. So we need to communicate with the physicians. So in summary, in this lecture we learn about adverse drug events. Can you tell me what's the two main causes of adverse drug events?
Medication errors.
Medication errors and the second one, adverse drug reactions. Which one is preventable?
Error.
Medication errors. Which one is usually not preventable? Adverse drug reactions. So which one we need to prevent? Medication errors. How many types of medication errors do we have? How many causes usually? You have dispensing error, prescribing, dispensing, administering, and monitoring errors. We have adverse drug events trigger tool. Can you summarize why we use this tool? ADE trigger tools. We try to identify any adverse drug events in the chart. How many causes for the medication errors? We have skill-based, we have rule-based, we have knowledge-based. We have two types of cultures. We have just culture, blame culture. Which one do you prefer? Why?
Because there is
Under-reporting,
and the blame cultures and will not correct the system. We need to correct the system so we'll prevent any future medication errors. Do you have any questions about today's lecture? Thank you so much for your attention.
بس بالنسبة للمونيتورينج error يعني if we have an inadequate monitoring for the efficacy of the drug, is it considered an error?
What do you mean by it?
يعني drug not working, but we not discover this.
When I say it's monitoring errors, I talk about adverse drug events. If we don't have harm, that's fine. I don't say fine, but it's okay if we don't have. We are looking for medication-induced harm.
Yes.
We are looking for medication-induced harm. But if we have inappropriate or ineffective medications, I think it's also considered monitoring. Or, for example, if we need to give the warfarin, and we know the warfarin INR, the ideal one, like usually between 2 and 3. If we don't give enough warfarin, we'll end up with what? With low INR, which is 1 or less than 1. If we end up with low INR, we may end up with what? With coagulation, with DVT. So it's all the way around. You will not have bleeding, but will have DVT, venous thrombosis or pulmonary thrombus. So I think, and sometimes it depends on the medication. If it's like antibiotics, okay, maybe. But if it's something serious like warfarin and we don't give the effective dose, that's why monitoring is not just only looking for the safety. We need also to look for, we need to control the hypertension. We need to control the efficacy. So our job as far in the United States nursing homes, They have pharmacists called consultant pharmacists. The role of this consultant pharmacist, they visit the nursing homes every month, and they get paid, and they review the charts, and if they find anything wrong in the medications, and they monitor the lab data, vital signs. If they find like warfarin without monitoring, they will send recommendations to the physicians, and the physician is required to answer. Doesn't require to answer yes or no, but required to answer. So they will send their recommendation to the physician to make sure, please monitor ANR, please measure thyroid function test, please measure potassium. So ineffectiveness, sometimes they are really harmful as well. We'll end up with the
Error.
error. It's a really good question.